Good afternoon. I'm Adam Myers. I'm the Chief Clinical Transformation Officer at Blue Cross Blue Shield Association, and we're delighted to have you join us today for this webinar about addressing the behavioral health needs of the workforce equitably. And it's important to note that last part, equitably. So with us today, we're delighted to have some real subject matter experts in the area. Joining us, we've got Dr. Christine Crawford, MD, PhD. She's the Associate Medical Director of the National Alliance on Mental Illness. Dr. Daryl Gray, MD, MPH, who is the Chief Health Equity Officer for Anthem Incorporated. Dr. Tom Allen, MD, he's Executive Medical Director, Behavioral Health and Government Programs for Healthcare Service Corporation, and Tara Sherman, Mental Health and Wellbeing Strategy Leader for Boeing. So our panel today, we'll talk for about 45 minutes or so and have some conversation, and then we'll open it up for some conversation with you. This is a crucial topic as we move forward together, and we've brought together this panel of subject matter experts to address the behavioral health crisis in America and its significant impact on certain marginalized populations. There are glaring health disparities across racial, geographic, and socioeconomic groups. In many ways, these disparities disproportionately impact people of color, and with people of color projected to account for over half of the U.S. population by 2050, it is very important as we move forward. And what are some of those disparities? Behavioral health disparities have serious impact on diverse groups, especially people of color. Only 1 in 3 who have a significant challenge are receiving care. People of color are 20 to 50% less likely to start and or stay in treatment. There is a 30 to 40% likelihood of underdiagnosis for a variety of reasons. Stigma is one of the big reasons for sure. Geographic impact, 80% of rural counties lack access to this. And then socioeconomic access, with 35% earning less than $40,000, which certainly limits people's ability to capture access as well. And then chronic conditions as comorbidities are 2 times higher likelihood in this population with people of color. So as we do so today, we're going to talk a little bit about how do we establish the scale of behavioral health across the United States? How do we address these specifically within employers and within the workforce? And what are some strategies as we move forward together? Because I use the word together because, as I like to say, none of us can do alone, but each of us alone can do our part. So as we move forward, I'll just jump right in at this point. In many ways, we've got a lot to talk about, so we'll jump right in. Let's start with the latest numbers on the prevalence and impact of behavioral health conditions within the American workforce. What are they, and how has the evolving approach to work brought them to light in recent years? And also, please include a personal story that speaks to the impact of these disparities if you have one. And we'll start with you, Christine.
Yeah, so thanks so much for the question. And also thanks again for having me as part of this panel, because we are really talking about an important topic, and that has to do with mental health. The reality is 1 out of every 5 adults experience a mental health related condition. And so I guarantee you that everyone on this call knows a couple of people, if not more, a handful of people who have been experiencing mental health concerns. And I think what has certainly happened over the last couple of years because of this pandemic, we all have experienced heightened sense of anxiety, sadness, trauma, and loss. And so what we've seen over the last couple of years because of the pandemic, that rates of anxiety, symptoms of depression have gone up 20, 30%. And as a child psychiatrist, I'm even seeing this in our youngest of patients, going as far back as preschool. And so it has had an impact on our kids as well as our adults. And we see that these numbers of experiencing significant mental health concerns has certainly increased. And then when we're thinking about our workforce is comprised of everyday people, right? So the same folks that I just mentioned in that statistic of 1 in 5 are the same individuals who are showing up at work. And so we all need to take on a sense of ownership and responsibility in terms of assessing whether or not our colleagues are doing well with regards to their mental health. I'll share a quick story about this. As we're transitioning back to doing everything in person, there's often a tendency to just quickly go through your meetings, trying to focus on what it is that you need to do. But what I found myself doing now that I'm in these in-person meetings is when I ask the question, how are you doing? How are you feeling? How are things going? I'm leaning into the question because I really want to know. And so I think now that we're transitioning back into this point in time where we're in person working, we all need to make sure that we're doing okay because we know that a number of folks aren't.
There's quite a bit that I want to unpack there. I mean, for one, you talked about the 1 in 5, which is an astounding statistic. But you also spoke to the pandemic and, social distancing has certainly led to emotional distancing for many. I wish we'd actually had a different term and a different way to go about it, but it's been a real struggle for so many with their standard support systems notably absent. Even churches and other gathering places were really kind of shut down for a while, and only now are we returning back toward more like business as usual. However, we as people are not in the same place that we were. So even as we regather and come back together, acknowledging that we're as individuals, as human beings in a different place, and maybe our personal needs have adjusted, and we've struggled pretty mightily as people and as families. So I appreciate you highlighting that. Tom, what are your thoughts about it?
Hi, good morning, and thanks for having me today. I agree with Christine and what you said as well. We've seen not only increased rates of mental health symptoms during COVID, but also increased rates of suicidal ideation, substance use, and overdoses. And this really speaks to people's distress. And, you said this, and that, our typical outlets for dealing with stress have been curtailed. We haven't been able to see friends. We haven't been able to go out and exercise or be in our faith communities or do what we need to do for wellness. Often these symptoms get worse and we need to speak to a professional. And I think the challenge is there have not been enough behavioral health professionals. Historically, there's been problems with access. One great thing about, if we can say there's anything good about the pandemic, is it's really expanded telehealth. So we've seen more doors open up for that. But also, there's a real need to be creative about how to get behavioral health services. More integration in physical health settings, digital applications for self-administered cognitive behavioral therapy. Mindfulness applications. I think what's good is we're really normalizing in a lot of ways the distress that we feel. We've all been essentially traumatized by this, and getting help doesn't have necessarily the stigma that I think it did pre-pandemic. It's become a little bit more universally acceptable. And just in terms of a quick story, I was talking to a colleague whose spouse died during the COVID pandemic, and she was really troubled. It's hard for her to go back to work because people ask her how she's doing, and certainly this is difficult to talk about. But the thing that affected her the most is people said, I can't wait until we can get back to normal. And she just, by hearing that statement, really understood that people don't understand her experience. She'll never go back to normal with the spouse gone, and a lot of us won't. but it's a matter of really accepting sort of the new normal and being open to what other people are going through, and being there to help and to listen. So I think, as we all go through this, I think that's what we try to do for one another.
That's a great reminder of how, as we communicate our desire to get back to, quote, normal, the realization that many just won't ever get to that point again, whatever the normal was before. It's just not an option anymore because life has changed so much. So we want to turn to a little bit toward specifically what are some of the disparities that people of color experience and in the behavioral health space, and what are some of the key contributing factors to these disparities? And we'll start with you, Daryl.
Thanks so much, Adam. Really appreciate the question. And again, to be joined by such esteemed colleagues is honestly an honor. These disparities, whether in underdiagnosis or otherwise, are plainly evident. And we do see it in underdiagnosis, undertreatment, disparate morbidity and mortality from mental health and substance use disorders, frankly. And, as we think about contributors, I think key contributors include include system level, provider level, and patient level factors, including inaccessibility of high quality and particularly culturally humble behavioral health care services, discrimination, stigma, and I think Dr. Allen just talked about some of the stigma surrounding behavioral health care, and overall lack of awareness about mental health and behavioral health. And unfortunately, as many of us know, this can be even further compounded for certain populations in which their intersectionality may increase their risk. So what does that mean? So there are examples of this that we see in lived experiences, such as among those who identify as being within the LGBTQ community and being low income, or those who identify as being Black and live in rural America. You can also, other contributing factors are a result of how people have to prioritize their health. We started, and I think you may have even mentioned it, Adam, in some of your introductory comments, but certainly as we think about behavioral health, we don't just think about that in isolation, right? We think about that in the context of physical health, in the context of people's social needs. And so it can be really difficult to prioritize your behavioral health if you're really focused on a social health need. Maybe it is housing security. Maybe it is food security. And so that may take precedent over going to see a provider around a behavioral health need. And so as I think really that kind of intersectionality of people's lived experience, that contributes to those statistics and those numbers that you highlighted earlier in your slide deck, Adam.
Appreciate that so much. Christine, what are your thoughts?
Well, I think all of the points that Dr. Gray made are spot on, but also to take into consideration the experience of going out and seeking help from a mental health provider. And we know that there's a lack of providers of color. We know that in psychiatry, about 1% to 2% of all psychiatrists are Black. And so for some people, there may be this hesitancy to talk to a provider who may not be of the same upbringing or have the same life experiences, and to sit in front of them and share all of these personal details, to be vulnerable with someone who may not have an understanding of what it's like to walk in your shoes. And for so many people of color, their experiences and their trauma has been invalidated by many people in a variety of different systems. So there's a concern that may happen to them again if they were to seek out mental health treatment. And we know that can be a trauma in itself as well, if you are disclosing what it is you've been through and someone is invalidating that experience and saying something like, well, I don't think it was that bad, or I'm not quite sure if racism was involved. And so that certainly can contribute to some of the barriers to folks actually wanting to go out and seek treatment. And also to highlight the fact that the historical context of psychiatry wasn't quite welcoming to people of color for many years. And so to have to rebuild the trust, not even rebuild it, to have to create and establish trust with the mental health system, within this community, it's so necessary and imperative because not a lot of people trust the system, not a lot of people have loved ones or older relatives who have seeked out treatment through therapy or medication management. So there isn't this natural kind of people passing down kind of what their experience has been like to engage in the mental health system. So we really need to encourage people to be open and honest about the positive aspects of their experience interacting with mental health, with our system, so that more people feel comfortable setting up that appointment, stepping through the door, and realizing that there is an opportunity to build that trust and to get the help and support that one needs.
Yeah, I think Crawford, can I just underscore? I love the comments that you've made. Go ahead, Daryl. Jump in.
I was just going to underscore. I really appreciated, Dr. Crawford, what you just said, and really two things I think really resonated. And one was the trauma. So not only might one experience trauma in their own household or in their own community or neighborhood because they recognize that they have a behavioral health need, but others say, well, why would you see a therapist? Why would you see a psychiatrist? Isn't that just for people who are crazy? So you have that trauma there, right? And then to then go see a provider that may repeat that trauma, reenact that trauma, or reinforce some of the things that people in your home or your community have said can be extremely damaging. I think your other point is so spot on in just talking about kind of mistrust. And I think what has happened too, and you highlighted this, what has happened as opposed to the system in regards to mistrust, in that, well, you as a Black individual or Hispanic individual or LGBTQ individual are too mistrusting of the healthcare system, when in fact, we who are part of the healthcare system, and I just say that globally, have been brokers of that mistrust. We haven't earned the trust in the way that we should. And I think we have a real opportunity to change that. And that's in partnering with individuals, with communities, to kind of foster that trust, that whether it's been through, and you alluded to this, Dr. Crawford, whether it's been through historical traumas, many of us know of whether it's been through research or clinical work on traumas and unethical practices that were fostered previously. But those still are well known in communities and passed down through that knowledge has been passed down through generations. So we have a tremendous opportunity. And I want to thank you, Dr. Crawford, for bringing that up.
Yeah, the other thing I thought I'd mention too is that oftentimes I think behavioral health, mental health challenges are viewed as a sign of weakness. And it's not unique to the communities of color or other minority communities. However, I think there's an additional layer of sensitivity there because people grow up as people of color almost with a sense that society is telling them that they are less than already for their entire sort of growing up time period. It becomes that sense of being less than, as I understand it, is very real. Why would somebody then take that additional layer and say, oh, and by the way, I also have this struggle right now, which I personally view as making me even weaker than that? Why would you make yourself vulnerable in that way when the system is not proven to be trustworthy? So I think it's a tough scenario. Tara, I'd like to get a little bit of perspective from you on this and shift towards you. What from an organizational and workplace perspective, let's talk a little bit about the emotional and physical well-being of employees as well as the economic cost to businesses. What's that prospect like?
Sure, thank you. And like the others, it's so great to be here, especially among these experts that I've learned so much from over the past few years and followed. The number that Dr. Crawford shared in the beginning, that 1 in 5 adults is impacted by mental health in the U.S., I actually use that one a lot with our workforce. We have 130,000 employees. And so in many ways, we actually mirror the rest of the country in terms of many health metrics. And that's also a really relatable number. When you think about it, what that means is when someone is in a team meeting of 10 people or a broader project that they're working on with 20, 2 or 4 people are impacted by mental health challenges. And that's the way I think we can really bring this to life, because for so many years, mental health challenges were someone else's family, someone else's coworkers. It's not us, it's not here. And that number really brings it home and helps us just say, look to either side of you. Likely someone here in this meeting or in this room is facing a challenge. And so I think that translates from the broader world and population into our workplaces very succinctly. I think there's also many organizations that have done research on the cost to the economy and the impact that a delay of care has in treatment or severity of illness. So we know the World Health Organization has estimated that anxiety and depression alone cost the global economy $1 trillion a year in lost productivity. That's only 2 conditions, and that's only productivity cost. That's not taking into account human life and suffering, and the fact that suffering impacts not only that individual, but quite likely their coworkers, their family, and teams that they're a part of. So in being with a manufacturing company, productivity absolutely matters to us, but we didn't approach this global mental health crisis just from a productivity perspective. We really preferred to approach it from a human perspective so that our employees can be their best every day, both inside and outside work. And that means we need to focus on giving them the resources that can help them live their best lives. When individuals don't get the help that they need as a society, we're not supporting that person and the broader impacts that will have. And that's why we've really focused heavily on increasing access to care, ensuring that care is high quality, helping find diverse providers, and breaking down barriers like stigma that can help people, that can prevent people from getting the care that they need. And with those impacts, we know that the positive economic impacts will follow.
Christine, what are your thoughts?
Absolutely. I think it's important for employers to rethink about to reframe their thinking around productivity. So often it's about meeting the bottom line, making sure that you're meeting the deadline, getting things done. But I think that over the last couple of years, there's been a greater appreciation for how mental health, for how depression, anxiety, how trauma-related symptoms can really take a tremendous toll on the bottom line. And it's really unfortunate that sometimes folks react and they do things differently when money is involved, right? But we know that it's had an impact on the economy, on a variety of different systems, but we need to invest in the mental health and social emotional well-being of employees, because if we're able to make it such that they feel safe within their organization, where they feel as though they have a space to talk about any difficulties or struggles that they may be experiencing, they'll feel more comfortable being in that work environment, being interested and eager to contribute to the teamwork. And that's because their mental health is being taken care of. That allows them to be productive. Because one of the things about being a human being is that we do like to have a sense of purpose, to be productive, to show that we are giving back. But if we're not able to have the mental capacity to do so, folks are going to feel bad that they're not productive. And so it's going to just kind of reinforce some of the mental health related symptoms that they may be experiencing. So we really need to prioritize mental health, mental well-being and to normalize conversations around it as well. And so if there are times in which an employee can't meet a particular deadline, they need to take a mental health day, we need to normalize that, because overall, that's going to result in more productivity if people are able to take the necessary steps that they need to protect their mental health so they can give back to the organization that they're a part of.
Well, we've unpacked a bit about what the scale of the issues are, what they are, what the origins of them are a little bit. Now we're going to shift a little towards solutions. Promotion of health equity writ large is part of our North Star at Blue Cross Blue Shield. Across the 115 million members that we support in partnership with you, many of the employers who work with us, it's critical that we tackle these issues. And we focused a lot on elements like the care and access and how that access is paid for, ensuring that high quality outcomes are ensured and incentivized across our networks. But let's talk a little bit about how employers can better partner with us and utilize health plan partners as a resource for advancing behavioral health equity. What are some of the important questions to ask? Tom?
Yeah, this is a good question. I think certainly, there are structural, sort of organizational solutions, definitely around policies with diversity, equity, and inclusion. But I think as a side note, we don't often know what we don't know. We don't know what we don't know, and it's important to collect data about our members, about our patients. I think with the lens of health equity, and to health disparities. Are we finding out about race and ethnicity? Are we finding out about geography, provider access? Are we finding out about, are we doing member satisfaction surveys? Do people feel attended to? Do they feel that their providers are culturally sensitive? Is there enough diversity in their healthcare professionals that they're seeing? So I think really finding out more information is important. And then, what do we do with that? I think, we've talked a good amount, and I agree with what everybody said about cultural competency, cultural humility, working with our caregivers, our staff, training around that, issues with implicit bias. But I think it's really important also to try, there's a power imbalance often between doctors and patients, and especially if there's a different, say the provider's white and the patient's from a community of color. What we want to do in our conversations with patients is to really level the field and try to reduce that power differential. So, meet patients where they are, understand what's important to them. What does health mean to them? Do they necessarily buy into the medical model? Do they look at faith? Do they look at different beliefs? So having that curiosity and that humility and that willingness to sort of, come down to the same level is really important. And even using other team members like community health workers, peer support assistants, anybody who's had a similar lived experience or, looks or, can relate to people that, that feels familiar to them. I think that'll help healthcare become a lot more accessible. So just a few different tools that we can look at.
Daryl, I know Anthem has quite a few partnerships with different employers. Tell us a little bit about ways in which that partnership has spread over into advancing behavioral health equity.
Thanks so much. And Dr. Allen, I just want to compliment you because I think you really covered the landscape there. And I don't think your points can be overemphasized. And so I'll kind of double click, if you will, on a couple of them. I think what you started out with talking about data, I think is extremely important. And so as I think about work that we do with employers and opportunities for advancing equity, I think, data exchange is extremely important because as we get information on members' race, ethnicity, gender orientation, sexual orientation, gender identity, geography, that allows us to provide that kind of culturally humble experience and optimize the member journey so that we can be that trusted partner, going back to some of the language that Dr. Crawford was using, but so that we can be that trusted partner in health, and particularly behavioral health. I think, allowing us to be able to exchange data is a critically important ingredient in advancing behavioral health equity. I think, too, the other piece is that as we work with employers, we want to make it clear that we hope to have no wrong door for engagement around behavioral health. And so as I say that, yes, ensuring that our Anthem members have access to in-person care, counselors, licensed behavioral health professionals, psychiatrists, et cetera. We also, yes, we do want to have that in-person care available, but also want to ensure that we have virtual and digital solutions available as well. And so certainly that's something that employers have been looking towards, and we've been very excited to offer to have as a part of Toolbox for members. I think another point you made, Dr. Allen, is extremely important, and that's around cultural humility. And to go back to some of the prior points from the discussion, anyways, and I think back to something I heard early in my training as a physician, and it was a quote: "People don't care how much you know until they know how much you care." And that is to say, and this goes to your point, Dr. Allen, around people being able to relate to what you say. You're not speaking over their head with medical jargon, but whether it's in the collateral that is sent to members in the mail, the outreach that's done digitally or virtually, or the in-person interaction, people want to know that they are seen, that they are heard, that the language that is used is reflective of their lived experience and their literacy. And so, as we work with employers, that's what we're working to offer. And I think the other piece that you mentioned, Dr. Allen, is in regards to partnerships. And so having partnerships with community-based organizations, for example, that are in the communities in which people live, work, play, pray, thrive, age, that's critically important to, again, establishing that kind of trusted and cultivating and sustaining that trusted relationship that will advance behavioral health equity. And so I think all of those pieces are extremely important as we try to move the needle away from those statistics that have been highlighted so far in this webinar.
Thanks so much for that. Tara, what steps are employers currently taking that have been effective in understanding and addressing behavioral health disparities and challenges facing segments of their workforce? What are you finding to be particularly impactful?
So number one, I think we've all had to do a lot of listening, always, but especially over the past few years, as to what is needed. And we've learned a lot. I think myself and a lot of other employers that are committed to this space have put in many different resources and really tried to start to support employees getting that specific help that they want and need. So I'll go over a few things that we've done. The first was mentioned earlier, was the expansion into virtual care. And we had started this before the pandemic in some ways, but I will say early into the pandemic, we looked at our numbers of general health care versus behavioral health appointments that were telehealth. And I'll tell you, that switch flipped so dramatically on behavioral health and has stayed very high. So we're seeing that, as someone else said, as a silver lining of the pandemic, especially when we talked about some of the disparities and inequities that come up from rural areas and from socioeconomic factors like like income. We're able to really help that in the area of virtual care. We also offer mental health coaching in addition to therapy. And again, that helps. It's virtual, so it helps it reach more people, and it's free to our employees. So true therapy may not quite be needed, or a person may not be ready to take that step. So we believe coaching is a great way to make use of a clinician's time and coach's time and give options to the person to find the care that they need. We also, through our partnership with Blue Cross Blue Shield of Illinois, have created a mental health navigator. And what this will do is kind of like customer service. An employer family member would call up, speak to a navigator, share what they specifically need. So do I want a Black male provider in this geographic area? Or do I want somebody that is LGBT competent and a female? And the navigator will do the hard work, finding the provider in network that is taking new patients and even make that appointment for our employee. They also will follow up to make sure it was a good fit, because we all know how critical that is to success. If it wasn't for any reason, they'll go through and help them find another provider. We have worked with Blue Cross to create specific guides for therapists that specialize in racial identity. And this has been really helpful to our employees. We've received a lot of positive feedback on that. We do a lot of education and question and answer session through what we call well-being hours, which are 30 to 60-minute webinars where we have experts on. We do some that target different segments of our population. So we have partnered with our Boeing Black Employee Association as well as our Boeing Pride Group to talk very specifically about challenges that impact that particular race or cultural group, and how to address those, or how to get the help you need, and answer questions with medical experts and behavioral health experts directly. And then just a couple quick final things that I want to mention is we've really worked hard to increase communications around mental health and normalize this behavior. It's been, I say heartwarming, but it's more than that. It has created such a sense of optimism in me about our future and the progress of all the hard work that we've all been making to see the response to some of these internal articles that we do. I think we've shared a couple on LinkedIn, but the support that comes in for the employee that shared their mental health journey, and the others that open up and say, it's so good to know we're not alone, or so many of us are impacted, has really, I think, helped to say these aren't isolated challenges. These impact a lot of us. The last thing is mental health ally program we've created and are launching. And someone did mention kind of peer support. This isn't meant to be counseling in any way, but we're launching a group of allies so that employees have more than their manager or HR to go to if they want to get connected to resources. And so we're really excited to do that again, to continue to get people what they need and remove barriers that stigma or being uncomfortable talking about a mental health need could bring.
Now, Terry, you spoke a little bit about normalizing behavioral health care across your organization, and some of that had to do with communication, some of it had to do with making it safe, some of it had to do with education, with the articles you described. What else are you doing for that, to help with that normalization of it? And again, it all has to be built on a foundation of trust.
Yeah, well, we have done some work with leaders, and we're working to do more. I think a big part of it is that education, talking about all of the resources that we have and sharing, so people see someone like me going through this. I think one of the early stories we shared was actually an executive within the company. And we hear both sides. We hear on one hand, it can be great for a senior leader to share a story. We hear on the other hand, people would prefer that it's more individual contributor because I can't relate as much to a senior leader. So we've actually utilized both. But I think having individuals at all levels share has been really helpful, and that there's no repercussions, there's no embarrassment. Seeing that this is a part of your health, just like every other part, I think has really helped us move the needle. But I will say, this has been a long road. We didn't just decide to do this one day and start, sharing these stories and journeys. We have been working toward this with our internal stakeholders for quite a while, because there was some hesitation at first about sharing some of this, what has been, called very private, sensitive information. But I just can't tell you how much value I have seen in the employee response to the fact that we have finally shared.
Now, Daryl, back to you real quick. I know that you're taking steps at your organization as well to work with your partners in the workforce space about how to address some of these disparities and help with these challenges. Tell us a little bit more about that, Daryl.
Thanks so much, Adam. I'm a strong believer, like many of you, that we as employers particularly must design for the outcome we seek. And I believe it was Dr. Paul Batalden who once said that every system is perfectly designed to get the results that it gets. And so as I think about us as an employer, and we have over 90,000 associates, certainly we have taken a health equity by design approach, if you will. And I'll use our example to describe steps employers such as us are doing to address behavioral health disparities. And Tara highlighted many of them already. First, I'll just say our whole health approach, and I mentioned whole health previously, but just to take a step back, it's really meeting the physical, social, and behavioral needs of our employees, members, and communities. But that kind of whole health approach is really reflected not only in our benefit design, but in network and culture. And Tara, I believe it was you who also mentioned kind of your employee groups. And I think about the work that we do with what we call our BRG, so our business resource groups. We have 9 of them. And I even think back just to last week, we had an amazing webinar or conversation. It wasn't even a webinar, it was a conversation with employees around behavioral health. And this was led by our Apex and Pride business resource groups. And it was a dialogue, and it goes back to something Dr. Crawford said about, ensuring that people have that safe space for dialogue. And I think as we work with employers and use ourselves as an example, you have to have breaking that kind of stigma that exists. I think, also we've created programs that help medical practices really address the unique needs of diverse individuals from diverse populations, if you will. And we brought together, whether it's strategic partnerships to build comprehensive interactive websites. So for example, we have tools, online tools that have increased the rate of screening for anxiety and depression and other health conditions, like our takeactionforhealth.org website for Black communities and Take Action for Our Health website for Hispanic and Latino communities. We've also developed internet-based learnings that help to improve the care that's offered, including behavioral health care for those within the LGBTQIA+ community. And so it's those kind of offerings. But, the other thing is we have to put our money where our mouth is as well, outside of those offerings and how it impacts people in communities where they reside. I think about, and I've shared this publicly before, but I think about an old professor from Ohio State, the late Dr. Frank Hale, who said, commitment without cash is counterfeit. And I'm really thankful that Anthem, our foundation, invested, over $13 million to support equity in behavioral health disorders, and particularly focused on substance use disorder. But we have, to your point about partnerships, whether it's our integration of Beacon to really heighten our offerings around behavioral health to those whom we serve. And I think about even what's happened since we've integrated with Beacon, how Beacon has partnered with the Kennedy Satcher Center for Mental Health Equity on the kind of equitable crisis response and launch of 988. I think about some of the provider racial equity fora that we've hosted to talk about openly implicit bias, grief and loss, racial trauma, and the intersectionality of people. And different trainings that we offer our providers, that we offer our associates, our member-facing employees. And so it's those things. But I also want to go back to a point that Dr. Crawford, I think you made. And you talked about the lack of diversity in the workforce. And so I think for us to be kind of, as employers, as leaders in this space, we also have to invest in the pipeline. of providers, increasing that diversity. And so one of the things that we've strategically done at Anthem is to invest in health equity scholarships to promote increasing the diversity in the workforce based on those who live in rural areas, those who identify as a member of the tribal community, or those who are underrepresented in medicine, those who identify as having a disability. And so I think taking that kind of holistic approach is how employers can continue to advance health equity.
Thanks so much for that. We're bumping up on the time where we're going to be starting to address some of the questions that have appeared in the chat room, but I want to bring a close to this part of the conversation before we shift to those questions. So given what we described so far, I'd like to ask each of you in turn to quickly mention maybe one or two top actions that employers should focus on right now. So Daryl, what are your top one or two recommendations?
You know, I just because I can only say one, I'll do something that's very broad that encompasses quite a bit. So I'm going to go back to the health equity by design piece. I think in all that we do as it pertains to behavioral health, if we don't design for the outcome that we're trying to achieve, which is behavioral health equity, regardless of someone's geography, their race, ethnicity, how they identify, sexual orientation, gender identity, then we won't get there. And so we have to design for it in the partnerships that we do and how we create safe spaces.
So what I hear you saying is be purposeful about it. It's not going to happen on accident. Be purposeful about it, and equity by design. I love that. Christine?
Lead by example. You know, we talked a lot about normalizing conversations around mental health, but we need employers, we need supervisors and managers to model that by being proactive and initiating conversations around the mental health and well-being of themselves as well as their employees. So sharing a story, sharing how the work week has been challenging for you, some of the highs and lows, and to have those as part of your regular team meetings so that other people know that it's a safe space to talk about what it is you're experiencing with regards to your mental health.
Tara.
I'm going to take the opportunity for two. So from the employer perspective, I would say, like Dr. Crawford, kind of drive it into your culture. Talk about it, write about it, educate about it. Just keep doing that more and more. And you can do that with almost no budget, actually. If employers do have some budget available, I would say continuing to look at programs or resources that can help improve access to mental health care, whether it be something like a navigator, like I talked about, or a special virtual mental health provider that can get access to appointments in a reasonable amount of time with the specifications that employee desires for their care. I think those are two things, one almost free, and one if there is some budget available to grow.
And Tom.
Yeah, just to reiterate what others have said, really anything to increase awareness, to normalize mental health, but also to reduce stigma. Whether it's understanding mental health in terms of, it's a brain illness. It's not dissimilar from other physical illnesses. It's treatable. Encouraging behavioral health treatment in physical health settings. But also in communities that are marginalized where people don't feel understood, and making sure that we have diversity in the workforce, that people understand implicit bias, that people have cultural humility to meet people where they're at. So.
Thank you so much. Now we've got a good number of questions here in the chat room, so I'm going to read them out and maybe ask some folks to respond. So Babette Schoenig wrote, are there steps that employers can take to reduce stigma for specific behavioral health conditions such as addiction and substance use disorders? What do you think, Tom?
Yeah, I think, this was said earlier. I think Tara said it, Dr. Crawford, Dr. Gray. I mean, we've all said it, but the degree to which our leadership can model an understanding and an openness to talking about behavioral health conditions, really sort of a sense of transparency is important. we're all struggling with what's been going on the last few years. We're all coping in different ways. And some of us are coping by increasing substance use, eating more. We're not living as healthy lifestyles as we want. But I think, kind of understanding that is one way that we're coping, and showing that there are other options out there, kind of leading them to different sorts of supports, different sorts of treatment outlets. And really talking about the person as a whole person, that there are other ways really to reduce some of the distress in your life.
Yeah, I think I like the way that several of you have emphasized whole person, because we do create a false dichotomy that it's either mental health or physical health, when in reality it's one and the same. It sounds like one of you wanted to jump in.
Yeah, just to add to that, we also need to be very mindful of the language that we use in our everyday conversations. So if we run into someone while we're at the copier machine or we're out in the hallway, to be mindful of not using stigmatizing language when describing individuals who are living with a mental health condition. Because as we've already talked about, 1 out of every 5 adults has experienced a mental health related challenge. And you don't know if that person who you're riding the elevator with and saying things like, oh, those alcoholics or these addicted people, you don't know if that person has also experienced something related to that, or their loved one or their spouse. So the more that we can use accepting, inclusive and non-stigmatizing language, that's going to further foster that safe environment that we've all been talking about, that's so key and necessary to ensuring a culture that really prioritizes mental health.
Thanks so much for that. Now, Monica Williams put this next question in. And we're going to start with you, Tara, on this. What have you and your team implemented to bring this to the attention of the manager level? And that employees tend to be scared to speak to their manager when they need a mental break for fear of being embarrassed or even worse, stigmatized.
It's a great question. And I can say we have done some things, and I think we're nowhere near, kind of hitting the goal yet. So we definitely increased our communications to managers. We did a few special sessions for managers on mental health and resources available. We have increased the amount of information shared, and we have a special manager news segment that goes out. We've increased it there. And we also believe that this mental health ally program that we're developing, I can't say we're the first out there doing this. I got some great ideas from Target and Accenture actually on this. So there's several employers, Delta Airlines also doing this. But that's a real key purpose here, is to help give people choices in who they go to for support. Now, the specific question about, if things are impacting their work performance, I think that we have manager training in place that assists managers with preparing for these conversations. I think we still have room to grow specifically on how they are better equipped to respond when the challenges come from a mental health perspective. So it's very real. I think we've made progress, but I think we still have more to do there.
Thanks so much. Anyone else have thoughts about how do you make it safe? Not just generally at work to discuss some of these things, but for people to feel like they can make themselves vulnerable about expressing these needs to the managers. Who else wants to weigh in?
I think it's important to praise and uplift and validate the people who are presenting their mental health concerns to their leadership and to management. And for management to also convey to that employee that they are being a good team member by sharing what it is that is challenging for them, that may be interfering with their ability to contribute to the team, to be productive. And that is that's an example of a good employee, of a loyal team member, someone who is really focused on themselves, as well as ensuring that the rest of their team is taken care of. So if we can kind shift the culture a bit to praise and uplift and validate the people who are presenting with concerns and say, well, thank you so much for sharing that with me. Yes, take a day off, take a couple of days off. That's really helpful, and we can reconfigure and regroup as a team. So we really need to praise individuals who are stepping forward, to disclose any challenges that they have, so that other people can see how leadership responds to that individual and know that it's a safe place for them to also share any difficulties they may be experiencing.
Who else wants to weigh in?
I would just add, Adam, in kind of a maybe tangential way, that I think we have to continually provide opportunities for education around this. And that's just to add on to what has been said, which I totally agree with, that there are some people who have not had a lived experience with having behavioral health challenges, mental health or substance use disorder challenges. And so providing the platform for education, providing platforms for dialogue, I think are critically important. I think back, one example recently that we had internally within our organization, one of our Medicaid plan presidents for Indiana, Kimberly Roop, shared a screening of a local film in Indiana. It was called Addict's Wake. Not just for those associates working in Indiana, but really across our enterprise, an opportunity to learn of some of the challenges that are faced in even a small rural town in Indiana, and how that could be applicable to other areas across the nation. And so I think the more that we can dialogue around this, and I'll use the word normalize that's been used across this webinar today, I think the better. And that's how we can continue to advance this within our workplaces.
Daryl, while you are on the spot, what are some thoughts that you have about virtual care, especially for systematically disadvantaged groups, and maybe a little bit about the digital divide?
Yeah, so I think of it in this context, and I appreciate you bringing up the digital divide, because certainly we saw how this has been manifested, at least early in the pandemic, where because we couldn't access our providers in the first surge for routine care, we quickly saw, again, being thrust into a digital health revolution where we saw disparities emerge. And maybe it was because people didn't have the Wi-Fi, the broadband access, or maybe they had the broadband access, but they didn't have the device, or maybe they had the device, but they didn't have the digital health literacy to have a meaningful interaction with their healthcare provider. And unfortunately, we're still seeing those things today. And so I think, virtual care is a great option to have in the toolbox. But we have to also understand that there are many who cannot leverage that option well. Maybe it's because the platform that's being used has not been made accessible, for example, for those living with disabilities, maybe visual impairment or hearing impairment. Maybe it's because the language that is used to access different features in speak English, or maybe the jargon that's used is not something that is well understood by all, and so the literacy level, the plain language, is not there for them. And so again, I think it's a great option to have, and particularly maybe for those, for example, who live in areas where there are geographic barriers to accessing even just routine primary care or routine behavioral health services. The virtual care option presents a fantastic resource. But I think there's some tweaking and fine tuning we need to continue to do for virtual care to make sure that it can be utilized by all. So again, underscore great resource. There's some fine tuning we need to do to ensure that it's accessible and utilized by all.
Well, we're at the point now where I'm just going to close things a little bit. And first of all, before I do, I want to thank each and every one of the panelists for joining us today. It's just been a tremendous conversation. Dr. Christine Coffer, Dr. Daryl Gray, Dr. Tom Allen, and Tara Sherman. Thank you so much. You've shared your insights, you've shared your time, and we're all better for it. But here are some of the things that I heard as we move forward. Partnership is critical. as we move into this space, and partnership between people that might be viewed as different stakeholders along the way that might not always partner together, but nonetheless, partnership is critical. It's very clearly between you as employers and your health plan partners. I love the phrase "no wrong door," meaning sort of multi-channel access to try to make it safe and equitable for people to access care in the ways that they most desire. That trust is crucial as we move forward. And there's a well-earned trust deficit in the behavioral health space, specifically for people of color. And that only through building relationships, seeking to understand where people are, rather than assuming that we understand, will we move past that and create that space of safety for people to lean in and get the care that they need. And then importantly, from a leadership perspective, modeling this is critical as we move forward. Modeling specifically to include what is sometimes very difficult to do, which is our own personal vulnerability, and being careful about the words that we use. I heard that very clearly. And then I'll wrap with one of the things that Daryl said, that the only way that we do this is by design. It is not accidental for us to achieve different outcomes. And so with that, I just want to thank you all. For more information, please check out the first 3 editions of our Health Equity mini magazine series and other resources at smarterbetterhealthcare.com. Thank you so much and be well.